The American Diabetes Association recommends 5 simple, evidence-based clinical tests to detect loss of protective sensation associated with diabetic neuropathy. Light touch with a Semmes-Weinstein monofilament, vibration using a 128 Hz tuning fork, Pinprick, ankle reflexes and vibration threshold testing using equipment that's a little more sophisticated. Any of these simple tests are considered clinically useful even when utilised on their own. Good evidence and common sense, however, suggests that combining 2 of them produces greater than 87% sensitivity in detecting DPN and loss of protective sensation. The current convention is to use the monofilament and one other test. The monofilament is widely considered a gold standard for detecting diabetic peripheral neuropathy. It uses the modality of light touch carried by large fibre neural constituents, and studies consistently demonstrate significant specificity for DPN. However, large fibres appear more resistant to damage than their smaller and poorly myelinated counterparts, appearing to resist the deleterious effects of diabetes for longer. Therefore, large fibre testing is specific for DPN, but probably not as sensitive as that of small fibres. So, in diabetic peripheral or polyneuropathy, cutaneous pinprick sensation carried by small fibre constituents, small fibre neuropathy, deteriorates early by comparison to touch, as tested by monofilament, large fibre neuropathy. Interestingly, vibration, by virtue of the comparatively delicate and resource-extravagant microphysiology that carries it, also deteriorates early on, but despite its large fibres, in contrast to both pinprick and light touch, it appears to degenerate so dramatically over relatively short periods that it may offer better sensitivity but less specificity. Surprisingly, then, despite its small, poorly protected fibres, pinprick seems to resist deterioration a little longer, and unlike vibration, is less vulnerable to the typical effects of physiological ageing. Pinprick has the potential to offer a level of specificity not available from vibration and sensitivity not available from light touch. This has been supported by good quality research, though sometimes by default, and hence is included in the ADA guidelines. In principle, therefore, sharp stimulation is an obvious choice to complement the monofilament when testing for LOPS. It should be able to provide us with the sensitivity that light touch cannot, but with more reliable specificity than that provided by a tuning fork. On a more neurophysiological note, pain is also a device intended to protect against insult, a function not usually attributed to modalities of touch, pressure or vibration. Indeed, unlike touch, pain is not a modality to which the individual easily habituates. Yet the human condition easily becomes used to the stimulation otherwise caused by clothing and hair. It may be cliché, and possibly the more powerful for it, that the gift of pain is a principal medium for establishing the value of pain to provide a protective mechanism against tissue damage. As a testing modality, pinprick sensation can be exploited for its sensitivity, reliability, and, if the technique is correct, for subtle specificity. Most of the time, in fact nearly always, pinprick is relegated or dismissed clinically because it is used only in a binary on or off fashion, asking, is this sharp or blunt, or can you feel this? All or nothing is bound to provide many false negative results because sensory loss is incremental. Essentially, where pinprick perception has diminished, patients can still report a stimulus, though there is no facility to express magnitude. The patient is asked only if they can feel, not how much. In consequence, pinprick only appears insensitive to neuropathy by virtue of it being applied to the wrong question. By contrast, continuous pinprick comparison, or CPC, is our recommended technique where the stimulus is applied in a novel way to promote both sensitivity and specificity. There can be no standardized neuropathy threshold superimposed upon the patient, especially in the early stages of damage. Everyone's perception is idiosyncratic and state dependent. Therefore, we can detect subtler, earlier deficit by using the second rule of clinical examination, comparison. The principle behind CPC is to introduce a reliable control stimulus where the subject is himself or herself made the control. Typically, when testing for DPN, the patient is assessed for sensory deficit in that part of the peripheral nervous system potentially most vulnerable to the effects of metabolic destruction, their extremities, and especially their feet and toes. The idea is to establish a level of normal sensitivity for them in a remote area of skin, supposedly unaffected by pathology therefore, against which the examiner can then compare the extremity. Verbal feedback can then be used to express differences between the two, and patients can be very sensitive to small distinctions. Thus, by introducing a control sensation, the technique is extended to demonstrating subtle loss, and employing Pinprick like this will look at deficit in a way that probably precedes the sensitivity of other modalities and more accurately reflect the progress of deficit if tested over successive visits. It can be further speculated that the long, evasive spectrum for DPN may well be revealed and exploited by the identification of subtle stage deficit that serves to predict serious complications, whilst intervention, either by means of medical, physical or pharmacological routes, can still be implemented to useful effect.